Hello, and welcome to Timing is Everything, a program of Care Dimensions. My name is Mary Crowe, Director of Professional and Community Education at Care Dimensions. We are continuing with our series of programs for you around hospice, a journey of care through the lens of the interdisciplinary hospice team. Today our topic is End-of-Life Care, Hospice from the MD's Perspective. We have the pleasure of speaking with Dr. Kristen Schaefer, Vice President and Associate Chief Medical Officer at Care Dimensions. Kristen, welcome to the show.
Thank you, Mary.
I'm so thrilled to have you on this.
Thank you.
Yeah.
Thanks for inviting me.
Oh, of course. So let's talk. I'm so excited to talk to the audience about this because this is so important that they understand this interdisciplinary team, and I'm thrilled to have you on from the MD's perspective. So tell the audience a little bit about yourself and your role at Care Dimensions.
Okay. Well, yes, as you mentioned, I am on the leadership team at Care Dimensions, and in that role I oversee hospice medical operations in our greater Boston area, and then I also oversee some of our innovative non-hospice programs, palliative care, and also our dementia guide program. But I'm also a physician in the organization, and I've been a physician for 28 years.
Wow.
The first third of my career I was in primary care and did hospice as a primary care physician, referring to hospice. And then the last almost 20 years, I've been a palliative medicine physician. I worked at the Dana-Farber and the Brigham as a consultant, and now 5 years here at Care Dimensions.
So why hospice? Why is this so special? What brought you to hospice?
Yeah, it's such a good question. You know, I think every person, clinician in hospice, has professional and personal stories of how we got here. You know, certainly for me, personally, I've had personal experience with hospice. You know, I grew up with a sick mom. Actually, it took me years into my career to realize that I grew up with a kind of fear of, and talking with her once I was adult, kind of fear that she could disappear, you know. But then even in my own life, just experiences with hospice. We had a child in hospice, and both my parents died in hospice.
Wow.
So there's that. I think as people in hospice, personally, we've had personal experience that give us really just an intuition, an understanding that there's work to do in this space to help people. And we want to learn the skills to do it, and it's very rewarding. Professionally, I had this amazing experience just from my age as a young doctor. I grew up during the AIDS epidemic. Early formative experiences watching my physician teachers, but also nurses and social workers and chaplains and community activists and scientists all kind of banding together to find treatment for AIDS, but also to be there for really good end-of-life care if people were dying of AIDS, you know. So I kind of have this bookend. Then I was privileged to be a part of the COVID pandemic just recently. So really a sense of mission as a doctor to get in there and help with serious illness, help people do as well as they can, and also make sure we have a commitment to care for people at the end of life.
Yeah, that's beautiful, and I feel that, you know, it's really a pull, isn't it? It's a calling. It's not just a job. There's so much more to it.
We kind of see we can do it, right? We want to do it, and then we realize we have the skills. Let's get in there and help.
Absolutely. Yeah, that's something that makes it so special. Can you explain to people, what is the process? What's the process in terms of, you know, bringing people onto hospice?
Yes.
That sort of thing.
Right. So it's hospice is a team sport, which is
it is.
which is the intention of this series, which is so lovely. And so, bringing people onto hospice is really a collaboration from our perspective as physicians on the team. We collaborate with the admissions team, who are nurses. It's always starting with goals. It's really a goals first kind of entrance. Like, we really want to talk with people and hear from people what their goals are. If they've been given news of a terminal illness or an advanced illness, what are their goals in the face of that diagnosis? And then we listen. Could that line up with hospice care, right? And it's a really important listening because people are in such, often, like I said, have just received terrible news. Maybe they've known it for a long time and they're very invested in the way they've been approaching it. Maybe they've just learned and are overwhelmed. We anticipate that these are emotional and also medically complex moments for people and their families. So we really want to get in there, understand their understanding and their goals about what's happening, and then we can make a recommendation based on what you're saying. This is what hospice could do for you and how hospice could help you. So goals first. The physician on the team at the time of admission, we have the responsibility of certifying terminal illness. So we have to look at the whole clinical picture and be able to say, yes, in our best judgment, this person likely has a life expectancy that's less than 6 months. That's the entryway to the Medicare hospice benefit and many private insurances. It's not set in stone. We're actually happy if people outlive their hospice prognosis, but at the moment that we're assessing people, we say, looking at your whole clinical picture, we wouldn't be surprised if that life expectancy is less than 6 months, and we have to certify that. I feel very happy with that structure of the hospice Medicare benefit, because it's not something you throw into a computer and get an answer. It really is a judgment. It's a clinical judgment that we in our medical training can look at the whole picture and certify. So that's a piece. And then the last piece, as we're planning for that hospice care, as physicians, we can anticipate what the trajectory of illness will be. So what's the likely course of this illness? What are they going to need along the way? What kind of transition is it from intensive medical treatment to medical care and hospice? And so we support the team in creating a care plan to help with that transition.
Yeah, that's wonderfully said. I just want to talk a couple of things that you had brought up. So first of all, when you were talking about listening, I just don't think there's a greater gift that you can actually do for another person. And that's one of the things that I love about hospice and palliative care. See, sometimes people think like people are trying to talk them into it. That's not how we approach this. And I love how you said that, because really it's about eliciting goals, values and goals from a person. And then how do we align that? And that's really how can they be of benefit in that way? And
we actually expect people to have goals or ideas that conflict with each other, right?
Yes.
Like, I want my loved one to live as long as they can, and I don't want them to go through things that cause too much suffering for them. And it's really not either or. It's really an and we kind of help people weigh in the face of where things are right now, what's most important and what is important, and how could hospice support you in doing that?
And it's a fluid conversation.
It is.
Because what is now might not be as things change.
It is.
So it's a really open conversation. It's never a one and done, is it?
No.
Yeah.
And and it's not like it's people think maybe like, oh, I have my treatment plan and then it's a big switch to hospice. It may be more of a bend in the focus, because it is what it is. People are struggling with these illnesses. They're working their best to do their best and feel their best. And so we almost add on this layer of, okay, if we focused things a little bit this way, then maybe things would be better and you would be more comfortable in this plan. But there are trade-offs, and we educate people about the trade-offs. When you choose hospice, there are trade-offs. Just like if you don't choose hospice, there are trade-offs. So we're very honest with people and want them to make an informed decision.
Absolutely.
Yeah.
And the other thing that you brought up, and I just want to highlight too, is just about the time frame, because people they get so rigid in this that they hear these criteria and they feel like this 6 months or less. It's really different from that, the way you described it. So, and people can be on for beyond that 6 month period of time very appropriately and continue to get that support.
Yes, absolutely. And nobody has a crystal ball.
Correct.
Each person's path is individual. And so our job as the hospice team is to assess how things are right now and what we can anticipate. And then as we go along, we see sometimes things change and you actually get a little better.
Right. Yeah.
And things might look a little longer, or we thought it was going to be a slow pace and then things change quickly. And so we really just assess in each moment as we go and try to share information, if they want us to the patient and their family and loved ones about what we're seeing, what they're seeing, kind of where are we in this trajectory of their own illness. Each person is individual. And I mean, it kind of makes sense that Medicare has to set some kind of limit to say this is how we want to approach someone's last phase of illness. So they pick that 6 months, but it's very arbitrary.
Yes.
Right?
Yes.
And so, and also nobody, no doctor, nobody can say, I know it's exactly 6 months.
That's
It's
right.
different. We look at the whole picture and say, I wish things were different, but it looks like time could be that short.
Right.
And if that's what we feel, then that person does qualify for hospice care.
Yeah. That's
just
well said. Yeah.
Yeah.
The in terms of the holistic, let's talk about that
Okay.
holistic approach
Yeah.
for a minute.
Yeah.
So let's define it first of all, right? Because
Okay.
you hear this
Yeah.
word holistic. What does it mean, and how do you ensure that for patients and families?
Yep. So holistic for me, and you tell me your definition too, but for me, it means whole person.
Yep.
Right?
Yeah.
Whole person, whole family. The person is at the center.
Yeah.
And let's care for them in all domains of their life and who they are as a person. And we do that in hospice with an interdisciplinary team, and also a team that has core values about functioning together, right? So we have physicians who are trained in medicine, we have nurses trained in nursing, we have social workers trained in social work, we have chaplains trained in chaplaincy, we have pharmacists trained, volunteers, the layers, and each of us bring our skill, but it's definitely the whole is bigger than its parts.
Yeah.
If we all bring our skills to the table and consider this person as a person together, we learn from each other every day about that person. Like maybe one member of our team had a conversation with that person. They share from their perspective. We develop a holistic understanding of a person and a holistic approach with every discipline we have to try to support them.
Yeah. And that's what it does. It means that to me as well. It's,
Yeah.
you know, spirit, mind, and body, we're a whole person.
Yeah.
And if we're not tending to that whole person, boy, are we missing the boat, aren't we?
Yeah,
You know?
we really are.
Yeah.
And we call each other on it, you know, like doctors tend to get a little jargony or more, you know, like we remind ourselves to talk in language that people understand, is to share information in a way that it can be understood. That's also an approach to a holistic care. It means you're communicating with someone in a way that they can understand you.
Absolutely.
You know?
Yeah, this is complicated enough, isn't it, from the individual's perspective?
Yeah.
It's scary, it can be overwhelming, and it's so important that we do this in a way that they can understand, that they can integrate, and it's not just going to be one conversation, it's going to be many to help them process that.
Another really refreshing part, it's easy to say holistic, isn't it? But one thing I think about the hospice model that really upholds that is our attention to family and caregivers and loved ones of the person themselves who's enrolling in hospice, right? Because we know that that person is really worried about their family.
Yes.
All sorts of worries. That family is really worried about that person, all sorts of worries. Hopes too, hopes and worries, but holistic, it's a special part of medicine that we actually, our mission is to lean in to that person and the person they tell us are important to them, right?
Yes.
And we bring resources to those people that our patient tells us, this is my chosen family, this is my people. We are supporting all of them as a network, and that's a piece of, really important piece of our services that line up with a holistic value, don't you think?
Yes, I do.
Right?
I do. I
Can't
feel
just be a
like
person by themselves.
No, these are skills that, again, I think that's where hospice and palliative care shine,
Me too.
is that they really tend to all of that, which is sometimes different from traditional medicine, isn't it?
It is.
Yeah.
It is.
Yeah.
In fact, I think that most people in hospice, well, I'll speak for the doctors, are really happy to be a part of an interdisciplinary team, really.
Yes.
If you're a doctor who's chosen hospice or palliative care, it's because you realize that.
Yeah.
You realize you're so much more powerful and better healer
Yes.
if you're working on a team.
Mm-hmm.
And so it's actually a source of resiliency for us that we're working on an interdisciplinary team as opposed to working alone in an office, for example.
Definitely,
Yeah.
Well, and you have patients that have a greater satisfaction at this precious time of life. You have families that do. And again, meeting the needs in all those areas, it just is a win-win in those situations.
It is.
Talk a little bit about some of the, how it can be challenging, certainly, in terms of kind of approaching these topics, all of that. I'm going to mix these because I want to talk about advanced care planning too.
Yeah.
I actually think we can kind of pull these two things into this one question.
Okay.
How do you approach it? How do you communicate with patients, families? How do you help them in that way? And also, where does advanced care planning and even goals of care, which is a cousin, right?
Yeah.
Conversations come in here.
Yes. So you're talking about the hospice physician. How do we approach it in general? Yeah. So we know as a hospice physician, we see and learn the whole medical record of what happened. And we also are in collaboration with the physician or clinician who referred that person to hospice and knows them well. So we come to a case as a member of that person's hospice team, really wanting to hear from them, what's your understanding of what's happened, where you are with your illness, what lays ahead. Because we find a lot of times a person and their family haven't had a chance to kind of put the pieces together, right? They may have been told things. Sometimes people are even shocked that they're in hospice. They didn't even, because there's so much, you're just taking in so much, right? And you're going through an emotional process of accepting what's happening or coping with what's happening. So so we always start by we know what we can about what's happened medically, and then we really want to know what the person and their family know and understand. And also what they've been told about what to expect moving forward. Because what our goal as a hospice physician is making sure that the patient and their family get to ask questions and have a clearer sense if they ask us, we can share with them our clearest sense of kind of where we are and where things are going and what's important now and what we might need to prepare for in the future. And you're right, it is about symptoms and it's also about goals. So symptoms, we pay attention. What's worked? What are the symptoms that are bothering you the most? What's worked? What hasn't worked? Let's not make a mistake. If people know, they know what's worked. They know how they feel. They know what's worked, what hasn't worked. And then we bring our layer of expertise to say, this is the way we think about treating pain. I wonder if this would be helpful if we added this or did this. And so we really try to educate people about symptoms and how we approach them. Hospice, we rely on the patient and their family to do a lot of assessment for us, right? When nurses come to visit and ask about symptoms, we want our patients and families, our nurses work so hard in the front line to really understand from patients and families what they're experiencing, right? And then they can call us and say, hey, doc, this is what's happening and this is how it was different and this is what we recommend to change. So the symptom management piece is really about assessing their symptom, but also their understanding what's worked before and letting them know this is like an active engagement and we're always going to be asking, how are we doing with this? And we have real expertise, nursing, medical, pharmacy, social work, chaplain, to lean into these symptoms and help, right? So it's a similar process. And then goals of care, sometimes people are missing information and we reach out to their doctor who knows them the best, or their team that knows them the best, and we help them get the information they need, right? About, wait, what happened? How did I get to this point? What are you thinking lies ahead? We really try to demonstrate to people, to engender trust with people, to demonstrate that we're collaborating with the teams who know them, and in the shared decision-making process of choosing hospice and moving forward, we really want to work with the clinicians who know them best, and keep in touch with them, and really bring our expertise, which we have, into their home, but also let them know that we're committed to understanding the past and working with their team that knows them. That's the only way this really works.
Absolutely. You know, and so when you're talking about shared decision making, I think that's so important, and it's probably a term that the audience hasn't heard very much. But it's so important, and I think they're going to be hearing this because it's so different. Because healthcare's had a shift, right?
That's true.
In terms of, you know, whatever the doctor said went to now really, we need our physicians. We need them desperately. We need their expertise. But as you talked about this whole time, how important it is to elicit from the individual and family, what are their values, what are their goals, and how do you align the treatment approach to that? Bringing all of that in. So, you know,
and also, like asking permission. People have been caring, and people have been caring for themselves, and their families have been caring for them through this whole illness, whether it's been long or short. And so asking permission to enter, and like, can I give you a recommendation?
Yes.
Shared decision making is about the doctor listening and thinking on your behalf, and then offering you their thoughts and recommendation, and helping you make a decision, right? And so, we realize we're new on the scene, so we have to do a lot of work to get to know people. They can get to know us and trust us as a team, that we're really in their corner.
Absolutely. I just think it's such a much more effective way, you know, where, again, if we're truly wanting to understand what's important from that person's perspective, that's the way to do this. Right?
And we love it when someone says, no, wait, my doctor said this. That's not what you're saying. Then we say, oh, let us call your doctor.
Right.
Right? Like, let's figure this out together.
And there's good communication there too, and I think that's really important that people understand, because I think people worry sometimes, well, I have to give up my doctor, when in fact that's not true at all.
It's the opposite.
Yes.
Yeah, it really is. But luckily, hospice physicians bring added expertise.
Correct,
So maybe your primary care doctor doesn't know as much about some of the medications we can use for symptom management, where it's very much our daily expertise. So we really just try to be an added layer of expertise for the family.
Well, I like that too, Kristen, because when you're talking about it, you know, you're talking about pain symptom management, so important, because there's a lot here. When you're talking about this holistic, if we're attending to somebody's spirit, mind, and body, how do we get to that? If we're not if pain and symptoms aren't under control, we can't get to the other stuff, which is so important for people. So it's so critical that we do that, and then we're able to address that, all of the other factors, all of the other facets.
And if you have a good hospice, which we are at Care Dimensions, every of the nurses are amazing at assessing symptoms and treating symptoms, because they do this, and they're in there listening and assessing and able to convey to us as the prescribers, this is what we see, this is what we think we need, and we don't have to wait, for example, to get a doctor out there to see. We work so closely with our nurses on our team. If a nurse on my team calls me, I know them, they tell me what's going on, I ask them questions, I can make a change and write a prescription to get something in there so that people don't have to wait. It's a good part of the model, because our nurses are so good at assessing the situation, and then I can follow up and do a visit if I need to. But it's not that sense of, we know that these things, time matters. We want to try to, you know, really address these symptoms as quick as we can, and so we work really closely. We partner with our nurses so that they're out there getting us information, and we're in their back pocket if they need us, you know?
Yes,
You know?
yeah, absolutely.
So we try to break through the bureaucracy of,
Yeah.
of waiting to see a doctor,
Yeah.
because our nurses are just in constant touch with
Yeah.
us.
Yeah, like you say, everybody's bringing their expertise in that area,
Right.
and that's what you need.
Right?
Well,
It works
you know,
well. It works well as a
absolutely.
model.
It is a wonderful model.
I don't think we wouldn't stay in it if we didn't think it did. I
Right.
feel great confidence that
Yeah.
we can help people with their symptoms and control symptoms with our model.
Definitely,
and
yeah.
that gives us confidence as clinicians. We wouldn't want to be doing this if we felt otherwise.
Right,
Right,
exactly,
so
absolutely.
It's good.
I have to tell we only have a couple of minutes left. I could sit here and talk to you all day.
Me too, yeah.
But we only have a couple minutes left, so I'm just going to ask you,
Yeah.
so what's that, give that gem, that one last thing you'd like the audience to understand that we might not have been able to touch on yet today, but is there anything you want to leave for the audience today in the next couple minutes?
Yeah. I'm so grateful you invited me. I would like our audience to remember that a hospice physician is a part of the hospice team.
Mm-hmm.
And our job is to coordinate care with your other clinicians, to use our expertise with our medications to make sure you're comfortable, and also, as best we can, to be a guide and a support to you and your family about what's happening medically, what we see could be happening, and a resource to you in terms of medical information, you know, all along the way. And I think not all people necessarily know that there is a hospice physician in the mix there with that intention,
Right.
to really support you.
Yeah.
Yeah.
I can't thank you enough, Kristen, for being on today. I really just value you and your input so
Thank
very
you.
much.
Me too, you.
And I want to
I
thank.
love the series that you're doing.
Thank you.
Good.
And I want to thank the audience for being here today, for taking part, and I look forward to you being a continued tuning in to more of our series on this interdisciplinary hospice team. So thank you again, and take care.
We don't focus on dying or how long they have left. We focus on whatever they want to do, whatever they can do, making sure that we can help them along.
Hospice care is really not just the physical care, but it's also the emotional and spiritual care as well. And we try to ease people into and through the process to hopefully make it as special and as meaningful a time for them as it can be.
It can be something much bigger than those final moments with someone. It can really help prepare the patient and family for eventual end of life. And I love that about it.